Welcome everyone. In today's high yield session, we are going to simplify one of the most commonly tested endocrine topics, hyperthyroidism versus hypothyroidism. Although both the conditions affect the same butterfly shaped thyroid gland, they produce completely opposite effects on the body's metabolism. Think of the thyroid as your body's metabolic thermostat. When it produces too much hormone, everything speeds up. When it produces too little, everything slows down. In this lecture, we will compare these causes, symptoms, laboratory findings, diagnosis, treatment, complication, and examples through easy to remember concepts and clinical cases. Whether you are preparing for MBBS exam, NEET PG, NEET, FMGE, USMLE, MRCP, or PharmD, this video will be helpful to you to master the thyroid disorders with confidence. So let's begin by understanding how one small gland controls the function of almost every organ in the human body. Let's begin with two real world clinical scenarios that perfectly illustrate the differences between hyperthyroidism and hypothyroidism. On the left is Miss Preeti Rao, a 28-year-old woman with Graves' disease, the most common cause of hyperthyroidism. She has lost 5 kgs despite eating more than usual and complains of palpitations, hand tremors, heat intolerance, loose stools, and scanty menstrual periods. Her heart rate is elevated at 112 beats per minute. Laboratory tests show very low TSH, markedly elevated free T4 and positive TSH receptor antibodies or TRAB, confirming the Graves' disease. On the right is Mrs. Kavita Sharma, a 45-year-old woman with Hashimoto's thyroiditis, the leading cause of hypothyroidism. She has gained 7 kgs without any dietary changes and experiences severe fatigue, cold intolerance, constipation, and heavy menstrual bleeding. Her heart rate is low at 58 beats per minute. Blood tests reveal markedly elevated TSH, low free T4, and high antithyroid peroxidase or anti-TPO antibody levels, confirming the autoimmune hypothyroidism. These two cases demonstrate the classic contrast between the disorders. Hyperthyroidism speeds up the metabolism, leading to weight loss, rapid heartbeat, and heat intolerance, whereas hypothyroidism slows the metabolism, causing weight gain, bradycardia, fatigue, and cold intolerance. Remember this comparison, it forms the foundation for diagnosing and managing the thyroid disorders in both clinical practice and competitive examinations. To understand thyroid disorders, you first need to understand the hypothalamic pituitary thyroid or HPT axis, the body's master thermostat for controlling the metabolism. Under normal conditions, the hypothalamus releases the TRH or thyrotropin releasing hormone. TRH stimulates the pituitary gland to release the TSH, thyroid stimulating hormone. TSH then signals the thyroid gland to produce the thyroid hormones T4 and T3, which regulate the metabolism, body temperature, heart rate, and energy production. When enough thyroid hormone is produced, it sends negative feedback to the hypothalamus and the pituitary, reducing TRH and TSH secretion. This keeps the system perfectly balanced. Now look at the left side of the slide. In hyperthyroidism, such as Graves' disease, thyroid hormone production becomes excessive. The high levels of T3 and T4 strongly compresses and suppresses both TSH and TRH. So TSH becomes most detectable undetectable. Despite this suppression, the thyroid continues producing hormones because TSH receptor bodies or TRAB directly stimulates the gland. The result is metabolic overdrive, an increased basal metabolic rate, excess heat production, rapid heartbeat, and weight loss. On the right side is hypothyroidism, most commonly caused by Hashimoto's thyroiditis. Here, the damaged thyroid cannot produce enough T3 and T4. In response, the hypothalamus releases more TRH and the pituitary secretes very high levels of TSH in an attempt to stimulate the failing gland. However, because the thyroid cannot respond effectively, hormone production remains low. This leads to the metabolic underdrive characterized by fatigue, cold intolerance, slowed heart rate, and weight gain. So, TSH and T4 move in opposite directions in the primary thyroid disease. In hyperthyroidism, TSH is low and free T4 is high. In hypothyroidism, TSH is high and free T4 is low. Understanding this negative feedback loop makes interpreting thyroid function test much easier. Now, let's compare hyperthyroidism and hypothyroidism system by system. Understanding these opposite clinical features makes the diagnosis much easier in both clinical practice and competitive examination. Let's begin with the cardiovascular system. In hyperthyroidism, excess thyroid hormone increases the heart rate, causing the tachycardia, palpitations, and sometimes atrial fibrillation, especially in older adults. In hypothyroidism, metabolism slows, resulting in the bradycardia and slow pulse. Next is body weight. Patients with hypothyroidism usually lose weight despite having an increased appetite because their metabolism is in overdrive. In contrast, hypothyroid patients typically gain weight mainly due to reduced metabolic rate and fluid retention. Regarding body temperature, hyperthyroid patients experience heat intolerance, excessive sweating, and warm skin, while hypothyroid patients complain of cold intolerance because their bodies generate less heat. The skin and the hair also show striking differences. Hyperthyroidism causes warm, moist skin and fine, silky hair, whereas hypothyroidism produces dry, coarse skin and brittle hair and hair loss. In the GIT system, increased gut motility in hyperthyroidism leads to frequent bowel movements or diarrhea. In hypothyroidism, intestinal movement slows, resulting into constipation. One of the most important examination findings involves the deep tendon reflexes. Hyperthyroid patients have brisk reflexes with hyperreflexia and a fine hand tremor, while hypothyroid patients show delayed relaxation of deep tendon reflexes, also known as hung up reflex, which is a classical clinical sign. The central nervous system is also affected. Hyperthyroidism commonly causes anxiety, irritability, restlessness, and insomnia, whereas hypothyroidism leads to depression, fatigue, poor concentration, and cognitive slowing. Finally, look at the menstrual changes. Hyperthyroidism is associated with oligomenorrhea, meaning light or infrequent menstrual periods, while hypothyroidism commonly causes menorrhagia or heavy menstrual bleeding. So, hyperthyroidism speeds everything up while hypothyroidism slows everything down. This single concept explains most of the clinical differences between these two common thyroid disorders. Diagnosing thyroid disorders is simple if you follow this four-step approach. Step 1. Always start with TSH, the most sensitive screening test. If the TSH is low, measure free T4 to confirm the hypothyroidism. Then check TRAB antibodies if Graves' disease is suspected, followed by appropriate imaging or treatment planning. If the TSH is high, measure free T4 to confirm the hypothyroidism. Check the anti-TPO antibodies for Hashimoto's thyroiditis and then begin appropriate management, usually with levothyroxine. Example: TSH first, free T4 next, antibodies last. This sequence helps the diagnose most thyroid disorders quickly and accurately. Let's compare the key laboratory findings. In hyperthyroidism, TSH is markedly suppressed, free T4 is elevated, and TRAB antibodies are positive in Graves' disease. LDL cholesterol is usually low, and alkaline phosphatase may be elevated due to increased bone turnover. In hypothyroidism, TSH is markedly elevated, free T4 is low, and anti-TPO antibodies are commonly positive in Hashimoto's thyroiditis. LDL cholesterol is often high, increasing the cardiovascular risk. In T3 toxicosis, free T3 may be elevated even when the T4 is normal. In subclinical hypothyroidism, TSH is elevated while free T4 remains normal. These patterns are frequently tested in medical examinations. Graves' disease is the most common cause of hyperthyroidism. It is an autoimmune disorder in which the TSH receptor antibodies or TRAB continuously stimulate the thyroid gland, causing excessive production of T3 and T4. The classic trait includes diffuse goiter, expothalamus, and peritabial myxedema. Eye involvement can range from mild lid retraction to severe optic nerve compression, making early recognition essential. TRAB positivity confirms the Graves' disease, and radioactive iodine therapy should be used cautiously in patients with active thyroid eye disease as it may worsen ophthalmopathy. Hashimoto's thyroiditis is the most common cause of hypothyroidism. It is an autoimmune disease in which anti-TPO antibodies and T cells gradually destroy the thyroid tissue, leading to reduced thyroid hormone production. Unlike Graves' disease, Hashitoxicosis is temporary and occurs because damaged thyroid cells release the stored hormones. Not because the gland produces more hormones, it is a TRAB negative and anti-TPO positive and has low radioactive iodine uptake. So, Hashimoto's is strongly associated with anti-TPO antibodies and carries an increased risk of primary thyroid lymphoma. Here are the four common mistakes to avoid in the thyroid disorders. First, never diagnose based on their symptoms alone. Always check the TSH. Second, before giving radioactive iodine in Graves' disease, perform an eye examination as it can worsen the thyroid eye disease. Third, in pregnancy, use free T4 instead of total T4 since the total T4 is naturally elevated. Finally, women with hypothyroidism who become pregnant should increase their levothyroxine dose by about 30 to 50% under medical supervision to support normal fetal development. Treatment depends on the type of thyroid disorders. In hyperthyroidism, the goal is to reduce the thyroid hormone production. Methimazole and carbimazole are first-line drugs, while PTU is preferred in selected situations. Propanolol helps control the symptoms like palpitations and tremors. Definitive treatment includes radioactive iodine or surgery. In hypothyroidism, treatment is levothyroxine taken on an empty stomach 30 to 60 minutes before the breakfast. Monitor the TSH regularly and adjust the dose based on the patient's response. Pregnancy requires special thyroid management. For hyperthyroidism, PTO is preferred during the first trimester to reduce the risk of the birth defects. From the second trimester onwards, switch to carbimazole or metamazole to lower the risk of liver toxicity. For hypothyroidism, increase the levothyroxine dose by 30 to 50% as soon as the pregnancy is confirmed. Early treatment is essential to support normal fetal brain development and a healthy pregnancy. Thyroid disorders can become life threatening emergencies. Thyroid storm is a severe form of hyperthyroidism with high fever, rapid heart rate, and altered mental status. Treatment includes PTU, iodine, beta blockers, and corticosteroids. Myxedema coma is an emergency form of hypothyroidism presenting with hypothermia, bradycardia, and reduced consciousness. Immediate treatment includes IV thyroid hormone, hydrocortisone, supportive care, and gradual rewarming. Both conditions are the medical emergencies that require immediate recognition and the treatment. Let's solve a quick exam question. This patient has weight loss, palpitations, heat intolerance, diffuse goiter, and eye signs which strongly suggest the Graves' disease. The most specifically antibody is TRAB, the TSH receptor antibody. Unlike anti-TPO, which can be positive in multiple thyroid disorders, TRAB is highly specific for the Graves' disease. So, propoptosis plus TRAB equals the Graves' disease. In India, iodized salt programs have significantly reduced the iodine deficiency, and today, Hashimoto's thyroiditis is the leading cause of hypothyroidism in iodine sufficient regions. For treatment, carbimazole is preferred drug for hyperthyroidism, while levothyroxine remains the standard treatment for hypothyroidism. Universal TSH screening during the pregnancy is also recommended for early diagnosis. In India, think iodized salt, carbimazole for hyperthyroidism, and levothyroxine for hypothyroidism. Let's quickly recap the points. Too much thyroid hormone points to Graves' disease and the key antibody is TRAB. Too little thyroid hormone points to Hashimoto's thyroiditis, where anti-TPO antibodies are most commonly seen. Remember, too much Graves, too little Hashimoto's. Thank you for watching this session. Please like, share, and subscribe our channel for more high yield medical content. Thank you so much for watching. Keep learning and keep growing. I'll see you in the next lecture. Until then, stay healthy and keep studying.